So what is the main goal of therapy, or at least our strategy to delay the progression of disease, is to prevent cardiovascular deaths by focusing on cardiovascular morbidity, treatment of disease process, the blood pressure and the blood sugar control, and avoiding nephrotoxic drugs. As I said, giving one NSAID to a patient with creatinine of 2.5 is going to be much more harmful than you are trying to control his blood pressure. So what is important is to have a comprehensive control. You can't have a one task approach. We will have to combine a lot of things together. We'll have to spend time to talk to him about lifestyle changes. We'll have to spend time to tell him about how quitting smoking and helping preventing the progression of CKD. We'll have to tell him how not chewing tobacco can also help him. So this has to require, this will require a multidisciplinary effort involving primary care physician, kidney specialist, endocrinologist, cardiologist, and dietitian. And we'll have to have a combination of physical therapies like exercise, nutrition, smoking cessation, lipid management, glycemic control, blood pressure control, then the drugs, and finally the antiplatelet agents. All these are need to be addressed, ranging from these factors, and this will depend on the severity of kidney disease, which will need to be modified. Now, first and foremost important thing is do no harm. Let's not try to push a patient into further progression by avoiding giving causing drug-induced nephrotoxicity. Dr. Anirban Gaugli, again, one of a Bengali student whom I had, and I'm very privileged that he's now a senior nephrologist in USA. We've written an article together on drugs and kidney, and we are going to rewrite that article again after a span of 15 years to come out with certain new drugs which can be. We keep on talking about Ramdev causing this, other allopathy, other pathies causing this, but we have plenty of drugs which can actually cause damage to our kidneys. And we need to understand that any patient whose age is more than 60, who has diabetes, who has a drug interaction synergistic with nephrotoxic effect, who has exposure to multiple or high doses of nephrotoxin. We talked about ambisome and how the WHO has described the way you should give an infusion to avoid nephrotoxicity. And of course, a person with multiple myeloma, a person with sepsis, or the person with volume depletion, these are the patients who are likely to deteriorate or have an adverse impact due to NSAIDs. Otherwise, taking an NSAID in a young, healthy adult may not be detrimental, may not harm you at all, but the same can happen, have an adverse thing. Second is the radio contrast. Again, it is similar. A person who is 60, who has diabetes, who has a creatinine of 1.5 is more likely to have damage with the contrast-induced nephrotoxicity as compared to a young adult who is undergoing a CT scanner, who is non-diabetic and hypertensive. So these are some of the risk factors: pre-existing renal insufficiency, diabetic, cognitive, congestive heart failure, hypertension, anemia, metabolic syndromes, hyperuricemia, and this is a pathogenesis. There is an oxidative stress, there's inflammation, there's apoptosis. So we need to understand that personal hydration. Ideally, a patient who is undergoing a DAS should be given hydration therapy. But if the patient is already in heart failure, then we have to reduce the dose of hydration as well. Instead of 120 ml per hour, we need to give it 60 ml per hour. So it has to be a personalized hydration. Pharmacological prophylactic agent, not much of a evidence, but remote ischemic preconditioning. These are the strategies which we need to employ to prevent contrast. What are the guidelines for slowing kidney function decline in patients with CKD? Well, there have been various guidelines. They have talked about blood pressure control. KDIGO has come out with 2012 and now 2021 guidelines. They've talked about blood pressure control. They've talked about how RAS inhibition not only can control blood pressure, but can also cause reduced proteinuria. They also talk about glycemic control, what should be the HbA1c target, and they've also talked about diet management. Then these various other guidelines have also talked about similar control. Now let's first come to blood pressure control. Now, there have been various trials, right from MDRD trial to Renin trial to sprint trial. We know about sprint trial very well. Then there's been ASSK trial and ACCORD trial. All of them have talked about renal protection and cardiac protection. So the important thing is to keep the blood pressure as near normal as possible. The earlier guidelines were less than 140/90. Then came the guideline that if you have a proteinuria, then reduce it to 130/90. But now recent guidelines have said keep the blood pressure, especially after sprint they have said that the blood pressure control should be as near normal as possible to possibly around 120 over 80. And among all the other medications, probably renin-angiotensin system inhibitor should be a part and parcel of any patient who's got diabetes, who's got CKD, who's got hypertension. Avoid a combination of the drugs, and they are of course contraindicated in pregnancy. Next to ACE inhibitors in ARBs, if your potassium is not an issue, then probably mineralocorticoid receptor antagonists have emerged as one of the key drugs which can help you prevent the progression of CKD. And there are certain newer evidence of which has emerged to describe the same.